Monday Subspecialty. We are so excited to have everyone here. I think it's going to be an awesome case. This is kind of one of our first overlaps, so it's going to be a rheumatology, hematology overlap case, and so I'm sure it's going to be completely mind-boggling. We're joined today by two experts, Mithu, who is a rheumatologist, and then Jori, who is a hematologist. And so we are so excited to have their expertise and sharing some of their thought process tonight. It's going to be a little different format. He's going to present the case, but then also as he's presenting, share kind of the thought process from the rheumatology side as they were thinking through it. And then Jori is going to does not know the case, and so we are going to hear the hematology case from her perspective. So before we get started, I was hoping Mithu and Jori would share their favorite things about their specialty.
All right. Well, I'm Mithu. I am a new rheumatology attending at Duke and excited to be here to present this case today. And thanks, Jori, for being my hematology counterpart. I would say one interesting aspect about rheumatology, I think, is the diagnostic process, which I think is very central to CPS and clinical problem solvers. So thinking through cases, trying to put together the history, signs and symptoms, lab testing, and kind of go through that process of solving rheumatologic cases and diagnoses is quite interesting and what I love about the specialty.
Well, thanks for having me. I'm excited to be here. And so I'm a benign hematologist at UAB in Birmingham and also relatively junior faculty. And you stole my response, Mithu. I think that's what's exciting about benign hematology is that, and maybe why they're, good overlap and why we're both here. But what I do, it's kind of, I would say an underappreciated sign of hematology and oncology, but the benign hematology side is really exciting. I'm never bored. There's always a diagnostic dilemma to sort through. And so it keeps me on my toes and keeps me learning, which is why I love
it. Awesome. Well, thank you all again. And Mithu, I think we are ready whenever you are to get going.
All right, sounds good. So today we have a case with the chief complaint of altered mental status. This, and I'll give you some information before we do some discussion of the first aliquot. So this is a 77-year-old female who is hospitalized with altered mental status and auditory visual hallucinations for 4 weeks. And she's on the general medicine service, but rheumatology and hematology are both consulted for a positive ANA and anemia. Regarding her altered mental status, she developed auditory and visual hallucinations, changes in her mental status, and cognitive difficulty. So she began not responding normally to questions, sort of seeming confused, and this has progressively worsened over the past month to the point now she's only intermittently responsive, not able to communicate in full sentences, unable to state her name or birthday, and at baseline, she had no cognitive deficits. She lived alone, completed all her ADLs independently. Regarding her anemia, she denies any epistaxis, melena, or hematochezia. She says, her family say, since she's not able to really answer questions for us, her family say she's not had shortness of breath or fatigue as far as they know the past couple of weeks. But with this altered mental status, she's been dramatically less active, mostly just kind of in bed. So that's it for the first aliquot, and I'll let Jori go first with some of her thoughts from a hematology perspective, and then I'll go after that.
Well, the altered mental status, I'm scared to venture too far into, so I'll start with thinking about anemia. We're concerned, though, I think more globally, right? This is something that hematology is involved, but there's something more global or systemic going on in this patient as well. And so that's the first thing that's coming to mind to me. When I think about anemia, there's only so far I can really go without laboratory testing, but I think it's worth mentioning kind of what I think about sending next in a patient that's anemic. What's the first test? I think a lot of times kind of the default, at least at my institution, is like an iron, B12, and folate, which I don't think is particularly helpful. My first test in an anemic patient is wanting to know the reticulocyte count. So it tells us what the bone marrow is doing in this patient. If the reticulocyte count is high, saying the patient's losing blood or consuming blood for some reason, the bone marrow is responding appropriately, versus a patient where it's not making reticulocytes. So we think there's a production problem that leads me down two very different paths in the differential. And so hate to always jump ahead to labs, but when it comes to anemia, that's where my thought process goes.
Okay, great. And one of the things about the subspecialty format of virtual morning report, we will try to jump to the labs a little bit earlier, actually, in today's discussion, because similarly, we really need labs to help us start narrowing our differential from a rheumatology side. So with this patient, I was actually on the inpatient consult service, so we were thinking about what could cause altered mental status, anemia, and a positive ANA. So first, when we see a positive ANA, I always think what diseases in rheumatology are associated with a positive ANA. We think about lupus, rheumatoid arthritis, Sjogren's syndrome, scleroderma, and myositis as some of the more common entities associated with the positive ANA. And then I think about what signs and symptoms based on history and exam would be potentially compatible with these diseases. So in this case, with ANA, anemia, and mental status changes, think about lupus, pretty high on the differential. And, we think about lupus erythritis that can cause CNS involvement with a small vessel vasculitis. You can get neurologic symptoms like altered mental status, psychiatric symptoms. That's why we sometimes call it neuropsychiatric lupus. And I think the CNS involvement, as Jori said, points to something more systemic. And for us, it's actually quite helpful in narrowing our differential too, because we don't see neurologic involvement in some of the ANA-associated diseases like scleroderma or myositis. It's extremely rare even in rheumatoid arthritis and Sjogren's syndrome. So it helps a little bit kind of narrowing some of the thought process in terms of our differential. And then also thought about CNS vasculitis as another big cause for mental status changes. And with a chronic inflammatory condition, you can get anemia of chronic disease with the normocytic anemia. So that was, something that could potentially fit in with our case. So next, I'll move on and give a little bit of additional information about for our next aliquot, past medical history, some of our meds, surgical history, and we'll do the examination and see if that gives us any clues in terms of the differential. So for her past medical history, she has a history of hypertension, hyperlipidemia, chronic diastolic CHF, peripheral vascular disease, and a history of DVT. For her medications, she's on hydrochlorothiazide, diltiazem, gabapentin, lisinopril, and atorvastatin. For her surgical history, she's had a hysterectomy, but was otherwise unremarkable. For family history, the family is not aware of any autoimmune disorders, neurologic disorders, or anemias that run in the family. For social history and health behaviors, no smoking, alcohol, or illicit drug use. Again, as far as family was aware, she had no travel recently and no sick contacts. She's not allergic to any medication. And can move on to our exam now. For temperature, 97.6. Heart rate was 103. Respiratory rate was 24. Oxygen sat was 99% on room air. In general, she was ill appearing. Her eyes were sort of closed, but would open in response to touch or to voice. And she is able to answer yes, no in response to questions, but not reliably answering correctly. For HEENT, she did have complete alopecia, so it was completely bald, and then no oropharyngeal or nasal ulcers. For her cardiovascular exam, she was tachycardic, regular rhythm with no murmurs. For her pulmonary exam, lungs were cleared auscultation bilaterally. For abdomen, soft, there were no masses or hepatosplenomegaly. For her lymph exam, she did have a non-tender 1 by 1.5 centimeter palpable left axillary lymph node, as well as some inguinal lymphadenopathy. And for her skin exam, she also had a few chronic hyperpigmented dark patches over the right foot. And for a neurologic exam, she was not oriented to person, place, or time. Her cranial nerves were intact. She was unable to follow commands to assess strength or gait, given the degree of her encephalopathy. She had 2+ reflexes at the knees and ankles. She did have purposeful spontaneous movement of bilateral extremities and did withdraw to painful stimuli. And her musculoskeletal exam, she had no synovitis, no deformity, tenderness, or fusion of any of the examined joints. So for this included shoulders, her small hand joints, elbows, wrist, hips, knees, ankles. Was all unremarkable. All right. So next, based on our exam, does this change anything, in terms of the differential or your thought process from a hematology perspective?
Sure. So I think, there's a lot to unpack here, right? So, I mean, first of all, just kind of her neurologic status. It's one thing we read about in the history, but to have kind of an objective examination that really shows that unfortunately she's having significant neurologic compromise. And, a lot of questions, this has been going on for 4 weeks, but, was this all of a sudden? Is she living at home? How has it progressed to this point? Because it looks like, unfortunately, this patient is quite ill. The complete alopecia is a finding that I'm really not sure what to make of, but is kind of surprising and not something I expected. From a hematology standpoint, I'm obviously going to start focusing on those lymph nodes. So a lymph node under, an axillary lymph node in an older woman, the first thing I'm thinking about is a malignancy, potentially a breast malignancy. But in conjunction with an inguinal lymph node, that makes me more concerned for something that's not as well localized. I wouldn't expect, a solid tumor of the breast to have an inguinal lymph node. That's out of the kind of standard zone that we would expect. So that suggests, again, a more kind of systemic process, lymphoproliferative process, or maybe a reactive process with lymph node involvement in both of those locations. Other things to highlight, I saw in the chat, I actually specialize in thrombosis. So obviously I'm gravitating toward her DVT and wanting to know why that happened. She's not currently on anticoagulation. So always considering how thrombosis might be playing a role in a patient that is tachycardic and maybe breathing a little fast. Not saying that we need to jump to a conclusion that this patient has a PE, but certainly important to think about given her history that we don't have a lot of detail about. So those are things that are kind of initially coming to mind. Again, I'm just really struck by her neurologic status. Clearly something that requires attention, but doesn't necessarily guide me too much more beyond just asking for more labs, which is what, as a hematologist, I'm always going to do.
That sounds good. No, I think that's a great sort of thinking through her examination, her vital signs, and looking at appearing, the extent of how severe her neurologic exam is, and see some good comments in the chat with ANA, lymphadenopathy, and alopecia. Could that be, concern for lupus? Thinking about infections and malignancy. We always keep that in our differential when we're also comparing with different possible rheumatic diseases. From rheumatology perspective, she's definitely very ill appearing. And the alopecia was quite interesting. So we did ask her family about that. They said, she lost her hair many, many years ago. They attributed it actually to some damage from some hair treatments that she had, but it wasn't exactly clear, sort of the time course of that, but it had been not something new, related to this acute presentation. Her musculoskeletal exam, again, for us is very, very important. So we want to see, are there signs of, inflammation in any of the joints? So we're looking for things like erythema or effusion. Sometimes with, rheumatoid arthritis, you can see deformities. And so those are some of the things we're looking for. That wasn't too remarkable here. The skin rash also doesn't seem too impressive if it's more a hyperpigmented, sort of chronic appearing rash, but definitely something that can be helpful for us with autoimmune diseases. Many of them can be associated with skin involvement. So you can get vasculitis of the skin with certain conditions, including lupus. And then lupus classically, however, when you do a biopsy, you often will see what's called an interface dermatitis. So that's sort of a classic histopathologic finding. But in her case, where it really does look more chronic and sort of only in a localized area over the right foot, likely unrelated to kind of her general presentation here. But something we always think about is sort of, can we get pathology and biopsy and to help sort of narrow our differential. And then definitely her neurologic manifestations seem to be really driving her presentation here. So, at this point, we were thinking from the rheumatology perspective, definitely lupus was very high on our differential, and CNS vasculitis could certainly present with some of these findings, but doesn't usually cause systemic lymphadenopathy, but was still kind of in our differential. So I thought next, and I think feel free to put in the chat, I've seen a couple of labs people have mentioned. I thought next what we could do is sort of go through what would be some of the initial labs that you'd want from a hematology perspective. So you guys can put in the chat some things that you might want, and then we'll have Jori help walk us through what some of these labs would mean, and then I'll try to go through and after that and let you guys know what they showed, and we'll kind of discuss those labs. So we'll give everyone a couple seconds to put stuff in the chat. And then while folks are doing that, Jori, you can let us know what are some of the hematology labs you'd want to know.
Sure. I'll just start chatting. So, first and foremost, right, that CBC is what we want to see. And not just the red, the hemoglobin, the hematocrit, the white count, and the platelet count. I want to see all of the indices. So I want to see the MCV, the mean corpuscular volume. I want to see the RDW, the red cell distribution width that tells me variation in the size of the red cells. All of that can be particularly helpful. particularly, even the white count, looking at the differential. Is there an elevation of the white count to suggest some sort of inflammatory process, which we're obviously concerned about in the setting of concern for rheumatologic disorders. But what does the differential on the white count look like? Is this neutrophil predominant? Are there other cells or cells that should be in the bone marrow that are in the periphery? So this CBC itself has so much information that I think we often skip past a lot of those numbers, and it's worth taking a look at. I see a comment for a peripheral smear, which I am a huge fan of. That should definitely be first on your list, because looking at red cell morphology is going to be extremely helpful here. Is there something unique here? Do we see red cell changes? Do we see, if we're worried about, I see a comment about a Coombs test. I would first expect to see if this is an autoimmune hemolytic anemia, spherocytes on peripheral smear. So it's a great way to kind of be a steward of labs, is to start with that peripheral smear and start narrowing your differential based on what you see. And then I already mentioned my favorite reticulocyte count, just to help guide us a little bit on, is this a myelosuppressive process versus a consumptive process? And I am more concerned about something myelosuppressive. If this patient does have a very active autoimmune disease, that markers of inflammation can lead to marrow suppression, but can also lead to consumptive processes like an autoimmune hemolytic anemia or something like that. So trying to keep it small in the beginning, I would start with, if you gave me my 3 tests, I've got my CBC with differential, I've got my reticulocyte count and peripheral smear, and from there would be able to make some more informed decisions, but certainly leaning heavily on my rheumatology colleagues to guide the workup from their perspective.
That sounds great. So yeah, we'll go through some of the hematology labs, and then we will get to some of the rheumatology labs after that. So first, from the I'll give you these answers, and we'll see what you think about the initial lab workup from the hematology side. So for her CBC, which was the first request, her white blood cell count was 5.4. She had an MCV of 84. And the differential on this, 75% neutrophils, 10% lymphocytes, 3% bands, 1% variant lymphs, and her platelets were 107,000. Her reticulous, oh, you asked about the RDW, so that was increased at 16%. And then her reticulocyte count was 5.8 with the percentage 0.24%. And then her peripheral smear showed hypochromia, anisocytosis, and poikilocytosis, but no schistocytes.
I might have missed it, but did we have a hemoglobin? I think you.
Yes, 5.7, and then the white count was 5.4.
Got it.
So based on these initial labs, what do you think? And then we can go through any additional labs you want.
So that's some anemia. That's not subtle. Certainly understand why this, brought some concern. It explains her tachycardia too, right? This is severe anemia, and definitely something that would cause symptoms. So a couple of things. This is a normocytic anemia, right? So that MCV, the size of the red cells is normal. There is the elevation of the RDW. Remember, RDW is a reflection of, if you have a bell curve of kind of the size of your red cell, so if you've got the MCV down here on the x-axis, and then the y-axis, now I'm thinking through it, is the number of cells of that size. So the width of that curve is your RDW. So if you have a lot of variation in the size of your red cells, that curve is going to be bigger. If all your red cells are the same size, it's going to be smaller. So it basically is a quantification of that aniso and poikilocytosis that you see on peripheral smear. So she's got some variation in size of her red cells. I'm guessing that reticulocyte count is probably a 5.8% of cells, and then the absolute number was maybe 240,000.
Yeah, I think that's right.
Yeah. So, and it's worth looking at your lab to see how they report these numbers, because it's extremely confusing. But there's usually a percent reported, so the percent of red cells, and then an absolute number. The absolute number is helpful if you're kind of more familiar looking at reticulocytes. What's really helpful is to calculate a reticulocyte index, which basically takes into account the percent of those reticulocytes and the current hemoglobin. So this patient is making a decent response. I would guess this would still be considered hypoproliferative just based on the degree of anemia, but she is trying to mount some sort of response. So this is not a completely, aplastic myelosuppressive picture. The other thing is she's also thrombocytopenic, so not to be ignored that the platelets are also low. Again, suggesting there's maybe something more broadly going on in this patient. So something like, we keep coming back to hemolytic anemias or things like that, an isolated autoimmune hemolytic anemia, you would not expect thrombocytopenia. So this suggests, again, there's something else more broadly going on here. You could have things like a thrombotic microangiopathy. So processes that lead to microvascular thrombosis that cause anemia and thrombocytopenia, but we don't see any schistocytes on peripheral smear. So again, this is kind of leading us in a lot of different directions, no clear answers here, but starts to kind of suggest that this is all maybe reactive or secondary to what's going on from her potential autoimmune perspective. So that's kind of my interpretation of what we have so far.
Okay, wonderful. And then before we get any additional hematologic tests that the audience and you would like, we'll go ahead and switch to the rheumatology perspective. So I've seen some labs in the chat, but feel free to add from our earlier segment. So I'll definitely give you guys those labs. And if there are any other labs that you'd want from a rheumatology perspective, you can add those in, and I'll start saying the labs for what we've gotten requested so far. So I saw inflammatory markers were requested. Her CRP was 1.8 milligrams per deciliter with a reference less than 0.6, so mildly elevated, and a sedimentation rate was 18. A ferritin I saw, and that was 307, which is within normal limits. Looks like UA was requested, so urinalysis showed 207 white blood cells, 18 red blood cells, 1+ protein, and a negative urine culture. I did see requests for antiphospholipid antibodies, so that's something we definitely want to know, given her thrombosis history with the DVT can cause neurologic manifestations, although, when I've seen it before, never, not typically this acute. But we did check those. So her anticardiolipin IgM was 21, mildly elevated. The remainder were negative. And let's see, we have requests for a rheumatoid factor and CCP, definitely in the differential with RA. I think we figured out her diagnosis before, and since she didn't have inflammatory arthritis, and joint pain, per the family history, I actually think we probably did not check those, but would be reasonable if you don't know what's going on and you're thinking about that. And then I saw ENA panel requested. So this was negative. And one of the points I wanted to make too is the ENA panel varies institution to institution, which ANA associated antibodies are included in the panel. So for us, this includes Smith, RNP, SSA and SSB antibodies, and some of the other ANA-associated antibodies, if you want them, have to be obtained separately. I see a double-stranded DNA, which was normal as part of our ANA workup, and an LDH and haptoglobin. We'll keep that with our hematology side. Let's see. Renal manifestation, thinking of lupus nephritis. So we were concerned about that with the seemingly active urinary sediment with a lot of white blood cells, red blood cells, 1+ protein. Her leukocyte esterase and nitrates were negative, but we did, get a urine culture. The primary team got that and it came back negative. So she did not have evidence for a urinary tract infection. And then there's one additional test that we think of with looking at renal involvement with lupus, and that's trying to quantify how much protein. So that would be one additional lab that we'd want for our second aliquot, or our next sort of aliquot. I think we're maybe on number 3 now. And let me see here. I think those were most of the labs so far. So putting the labs together from the rheumatology perspective, lupus comes high on the differential now, because we have a positive ANA, anemia, lymphadenopathy, the alopecia, proteinuria, and thrombocytopenia. And sometimes these patients can get mild increases of their antiphospholipid antibodies, even if they don't have meet clinical criteria for antiphospholipid antibody syndrome, which she does not, because her level is not, elevated to the degree necessary for that. But, that could even fit with her potentially for lupus. So that was certainly high on our differential. We thought about possibly antiphospholipid antibody syndrome, but again, once the antiphospholipid antibody levels came back, that was more reassuring against that diagnosis. And there were a few other potential possibilities, but we have a few labs missing to kind of put those in our differential. Next, why don't we do this? We'll see if there are any additional labs that you all would want. First, from the hematology perspective, as part of the anemia workup, Jori, if you want to fill us in on any additional tests you'd want, knowing the initial test that we have with our peripheral smear and reticulocyte count, and then we can go through those, as well as any other additional testing that you all would want, imaging or other studies after we do the hematology.
Sure. So, I think there was a comment about an LDH and a haptoglobin, which I think is a really good one and important here, because again, I do think, we're seeing some reticulocyte response. So there's some degree of consumption here. So in the absence of any sort of bleeding, at least that we are able to get from the history, looking for a hemolytic or a consumptive process is going to be really important. So I would absolutely send those next. From the laboratory perspective, I'm not sure if there's any kind of easy answers that I would jump to. I think, talking about a Coombs test is important, but again, we didn't see those spherocytes that we would expect to see in a typical kind of robust autoimmune hemolytic anemia. But if we did see an elevated LDH and undetectable haptoglobin, that might point me to getting that DAT. I'll tell you, I'm trying to be a steward of these labs, right? I don't know if for those of you at certain institutions that we're all really struggling with a blood tube shortage. So being very strategic with how we order labs, I do think is important to emphasize here, particularly in these hematologic, rheumatologic overlap cases, right? We could send all the labs, and particularly in a patient with a hemoglobin of 5.7, she doesn't have a lot of blood to spare for labs. So trying to make sure we don't jump to things too quickly is something I always try to keep in mind. So that's kind of where I would start from labs. And then I really want to know more about these lymph nodes. So I do, from an imaging perspective, Mithu, you started to mention that question of saying, is there some imaging that we can obtain to better understand the extent of her lymphadenopathy, and if that might be helpful for us? Because right now, because the labs are not as revealing, what I'm looking for is something to stick a needle in, honestly, right? Is something that's going to give us that kind of next step and clues. And if we have a revealing lymph node, that would be very important. There are a lot, the differential for lymphadenopathy and anemia in a patient with altered mental status is extensive. We have, infectious causes, we have malignant causes, we have all sorts of inflammatory disorders, even kind of rare disorders like histiocytic disorders. I mean, the list is quite long. So understanding that lymphadenopathy, I think, is going to be a huge part of this, to make sure that that's not a road that we need to go down in, making sure we don't potentially need some sort of lymph node biopsy. So that's kind of where I would put my money and next steps from a hematology side.
All right, wonderful. And let's see, anything else that you guys want from the rheumatology side? We'll go ahead and get all of our additional labs first, and then we can go through what those showed with our additional requests and chat through those. So looks like a couple folks mentioned a few additional tests, which were, I was hoping to see complements. We always think about complements when we're evaluating for lupus. And so her C3 was low at 72. Her C4 was low at 12. So she had hypocomplementemia with both low C3 and C4. I'm quantifying the proteinuria. So this is called a urine protein to creatinine ratio. Tells you how much protein is in the urine. And hers was 1441 milligrams per gram. Normally, we want that less than 200. So she had significant proteinuria. And then I mentioned any other testing that we would want. I know imaging has been mentioned a couple of times, so I'll go ahead and go through that. And we also did it, the team did an LP. So first, her MRI brain showed mild to moderate supratentorial white matter punctate T2 and flare hyperintensities, which can be seen with small vessel disease versus vasculopathy, including possible autoimmune etiologies. She had a CT chest, abdomen, pelvis, which showed axillary, retroperitoneal, and inguinal lymphadenopathy. Had a LP showing a normal cell count of 1, normal protein, and normal glucose. She also had elevated oligoclonal bands in her CSF, but also in her serum. And so the difference between her serum and CSF oligoclonal bands was 0, which I will discuss a little bit about that. And let's see, we went through the antiphospholipid antibodies. I think that was most of the additional imaging. And then to answer the other questions, the urine microscopy did not show casts. And then we'll go through some of the additional hematology labs, and then we can talk through what we are thinking of in terms of our differential now. So there was a lot of discussion that I thought was in the chat as well about the DAT testing. And I think, Jori, you made a very good point that we always want to think about the labs that we're sending and whether it's going to change your management and sort of your clinical suspicion for things. In this case, she did have the DAT sent, which was interestingly positive with both IgG and C3. And then given the DAT positivity, she had additional testing sent, and there were cold agglutinins detected. We were not sure why there weren't spherocytes on the peripheral smear, but she had the DAT positivity. Sometimes in lupus, we'll see patients with a positive DAT, but they don't have clinically significant anemia, so that was a possibility. And then the cold agglutinins was sort of an interesting additional finding that got sent. So knowing this information, I'll let you go next, and then I'll follow with kind of an updated differential on what you're thinking.
Yeah, so this opens up a whole new area for discussion. So I presume then, her LDH would be elevated and haptoglobin undetectable. That would suggest she was having ongoing hemolysis, because you're exactly right. A DAT can detect antibodies that are not clinically active. So we certainly need to make sure that there is evidence of hemolysis. So you mentioned when we read a DAT, we look at kind of two things. If we see IgG and C3 on the surface of those red cells. The typical pattern, so if you see IgG bound, that tends to be a warm autoimmune hemolytic anemia, so one that tends to have warmer binding temperatures. C3 positivity, usually if you're seeing a cold agglutinin, what you expect to see is IgG negative, C3 positive DAT. So this is a little bit surprising. You can certainly have a combination of both warm and cold antibodies, so a warm autoimmune hemolytic anemia along with a cold agglutinin. But again, the DAT is not a perfect test. But under the assumption that she has, presumably here a cold agglutinin disease, can be associated with a lot of other disorders, particularly lymphoproliferative disorders, autoimmune disorders. So suggesting that, again, this maybe is a hemolytic process that is coming in conjunction with whatever else is going on from a systemic standpoint. The important thing is when we think about managing that, really management of any sort of autoimmune hemolytic anemia that's secondary to some other disorder is controlling that other disorder. So very important that we actually figure out the driver there. It can be idiopathic, but in this case, I think that's less likely given we have all this other symptomatology that we're working up. So quite interesting, a rare finding, and certainly need to know a little bit more to figure out how to best treat it.
Wonderful. And then a couple of people have mentioned a couple other tests they wanted. So we didn't go through the basic metabolic panel, but her serum creatinine was elevated 2.1, and she had a BUN of 65 milligrams per deciliter. The rest of her BMP was unremarkable, and her liver function tests were normal. And then, from the rheumatology side, we definitely started to, we were sort of interested in putting all of these pieces together. Could she have a rheumatologic diagnosis. And interestingly, we had them repeat the haptoglobin and LDH, and she did have a drop in her haptoglobin, her LDH increase. So she sort of developed a more clinically significant hemolytic anemia. And so then she had this mixed warm and cold autoimmune hemolytic anemia going on. And she was started on IV steroids to kind of treat that hemolytic anemia in the meantime, while getting some of this additional workup. So I'll go through some of the things we added to the differential with these lab manifestations from the rheumatology perspective. So, I think a lot of folks have mentioned lupus. So now we have the ANA, we have low complements, the proteinuria, thrombocytopenia, hemolytic anemia, lymphadenopathy, and this alopecia potentially in the past. So that's one of the things we think about with lupus, is that you can meet the classification criteria with symptoms over any time point. It doesn't have to be all sort of simultaneous. We started to think of some other rarer possibilities. So IgG4 related disease can cause lymphadenopathy. It can cause renal involvement. And with that, you can see proteinuria and hypocomplementemia. Doesn't usually cause this degree of anemia though, so that didn't quite fit. And then rarely can cause CNS involvement with what we call a hypertrophic pachymeningitis. TTP is an interesting thought, and Jori could speak a little bit about this, but in her case, she didn't have schistocytes on her smear, so that is a little bit reassuring against like a microangiopathic process. And then we thought about APS, but again, we had the antiphospholipid antibodies come back, but initially we actually didn't have them. We had the low complements. We thought about low complements, thrombocytopenia. You can actually get a nephropathy with APS, which is a thrombotic microangiopathy. Again, she didn't have the schistocytes on her smear, but APS, so antiphospholipid antibody syndrome, can interestingly cause low complements. So it's always important to think about that, because sometimes I think, I've seen patients get misinterpreted as like having lupus, but they really probably only have primary APS. And then we considered the possibility of, infection. Jori had mentioned lymphoproliferative disorders at the very beginning. So we thought about the possibility of, is this a lymphoproliferative disorder? And then some infections can cause a cold agglutinins like mycoplasma and EBV. So we thought about that. And so next, how are we doing on time? I can go to the last aliquot and reveal the diagnosis next. What do you think, Anne-Marie?
Probably 15 more minutes, so I'd be happy to hear any more kind of thoughts or discussion.
Okay, sounds good. Yeah, we can do that first before we get to the last aliquot. And let's see. So I think one of the things we could talk about, what do you think, Jori, in terms of like how you would manage a autoimmune hemolytic anemia, and are there any things different with sort of a warm versus cold and then this mixed autoimmune hemolytic anemia?
Yeah, so that's a great point. And I think there are some questions. Again, I just wanted to clarify the reason we know, or we're calling this kind of a combination of a warm and cold process, is basically the DAT finding. So along with a cold agglutinin titer. So warm autoimmune hemolytic anemia on the DAT, you would expect to either see an IgG positive C3 negative or IgG positive C3 positive DAT. And basically what that's telling you is that you have IgG immunoglobulins on the surface of the red cell that do or do not have the ability to fix complement. In general, for the cold processes, we expect that this is driven by IgM. And so we see a DAT that is IgG negative because it's IgM driven, and C3 positive because IgM is able to fix complement on the surface of the red cell. So the fact that we see this IgG positivity as well as we have a detectable cold agglutinin, that suggests that we have a combination process here. And the importance is that, so steroids are great for treatment of warm autoimmune hemolytic anemia. Steroids will do nothing for cold agglutinin disease. However, if the cold agglutinin disease is due to a steroid responsive process. So if you're ultimately treating the underlying disorder that's causing the cold agglutinin with the steroids, you might see some improvement. But true cold agglutinin disease requires escalation of therapy. Usually rituximab is considered first-line therapy for cold agglutinin disease, can also treat warm. But that's kind of an important distinction, is that if you have isolated cold agglutinin disease, steroids are not going to cut it. But certainly makes sense in this case where you have a combination of both. You're concerned that this patient is having significant hemolysis, also with potential for an autoimmune disorder, steroids can be helpful. The one thing to keep in mind is if you are hoping for finding some sort of lymphoproliferative disorder and you're hoping for a lymph node biopsy, you start those steroids, you do worry somewhat about the yield of that biopsy. But that being said, if you really need to, the safety of the patient comes first. If the hemolysis is so robust, you need to start something, then steroids are certainly appropriate, and hopefully the patient did have some response in order to stabilize her hemoglobin. I will put in too, so what'll show up on your boards and step exams is the question of how do you transfuse a patient that has autoimmune hemolytic anemia? And the response is least incompatible blood. So basically, if you think about it, right, there's all these antibodies on the surface of the red cell. So how can you do typing for alloantibodies? How can you actually test to see if those blood products react? You really can't, because there's antibodies bound everywhere. So basically, we have to make our best guess, and we call that least incompatible blood. So in a patient who does require transfusion with an autoimmune hemolytic anemia, we have to work really closely with our blood bank colleagues and basically match as close as possible. So interesting pathology on the hematology side.
Wonderful. And then a couple of other discussion points. I did see renal biopsy. So that is definitely a consideration in this case as we're working up this patient. We're thinking, possibility of lupus, and she has proteinuria. So we always try to get a kidney biopsy if we're concerned about lupus to see the class of lupus nephritis. But we did end up getting to a diagnosis before we needed to proceed with a renal biopsy. And then the second thing we think about is with the CNS involvement and, the possibility of a CNS vasculitis or lupus cerebritis, we'll sometimes look to see, what are the steps that we can work up for that. So we talked about getting the CSF studies. And one of the things that you can interestingly see in lupus is sometimes elevated oligoclonal bands in the spinal fluids. You can see that with multiple sclerosis and other disorders, but from the rheumatology side, you can actually see it with lupus. And so what you do is you actually have to send for the oligoclonal bands in the serum and then also the CSF, because if you have a systemic disorder, they'll be raised in both. And that was what was sort of in her case. And so you can subtract the serum from CSF. And if you have more oligoclonal bands in the CSF, that suggests a more CNS inflammation, CNS inflammatory process. So we were a little bit perplexed with the degree of her CNS involvement. If this was lupus, we would actually expect to see inflammation in her spinal cord, including elevated cell count and usually an elevated protein. And like I said, her cell count was 1, her protein was normal, and then she didn't have the oligoclonal bands. So we were a little bit perplexed by the fact that she didn't seem to have lupus cerebritis, or at least inflammation, I should say CNS inflammation that would be seen with lupus cerebritis. And the other thing we didn't discuss that we think about when we're looking at the labs that we're ordering is, I mentioned positive ANA, but no one asked about the titer of the ANA or the pattern. So her ANA was 1 to 640 in titer, and it was a speckled pattern. And I think one of the things that is helpful is, like, when you think about an ANA and when it comes back positive, what does that mean? So we know that the ANA basically means you have antibodies against some type of nuclear antigen. And so there are a lot of specific antibodies associated with ANA, depending on the pattern, and different diseases that can be associated with specific patterns. And interestingly, there's a lot of overlap. So they're not super specific, but the higher the titer, the more we think of it as sort of the more potentially clinically significant. And so, if you have an ANA of 1 to 40 or 1 to 80, that's not very specific. And as your titer goes up, it can sort of become more clinically significant. So always remember, when you see an ANA, about 15 to 25% of the healthy population can have a positive ANA. So it's not diagnostic, specifically of any particular autoimmune disease. And there's an interesting little infographic and tutorial that Anne-Marie and I made. So I'll link that below so that you guys can check out sort of how we think about interpreting a positive ANA. And so I wanted to briefly get into that discussion today. And the other thing I wanted to mention is with the MRI brain, it's important to know when you're thinking about lupus erythematosus that the MRI may not show specific changes or inflammation, because this is often a small vessel disease with lupus erythematosus, for example, and even some types of CNS vasculitis are very small vessel. And so an MRI may not even show any changes. Sometimes we'll try to get an MR angiogram of the head or MRA. And then if you're very suspicious of a vasculitis, then conventional angiogram is the best to kind of visualize the cerebral vasculature, see if you see beating that can happen from inflammation in different parts of the vessels. So those are some little pearls with the neuroimaging. And the other thing I think is interesting to think about in this case is the mixed autoimmune hemolytic anemia. So that's quite unique and doesn't have a super long differential, but can be seen in autoimmune diseases like lupus and Sjogren's. So that was also something that we thought was sort of interesting as we thought about the differential on this case. So let's see. We can move on to the fourth aliquot. Next, what do you think, Anne-Marie?
Yeah, let's anyone have any final thoughts? Is it going to be the big reveal?
Mm-hmm. So if anyone has any other questions or things they'd want to get, additional tests they'd want to get, tissue will be the issue. So this is a great segue, you know, and I'll kind of go through that. So certainly we want some pathology to help us kind of piece together this process. All right, well, I will go ahead and let you all know what we did next. So one of the things I didn't mention, but we, thought about through this case is certainly a lot of clues were suspicious for lupus, but we were a little bit suspicious of that diagnosis also because she is 77 years in age, and lupus tends to present in younger females classically. So the fact that, she's in her 70s is this really like new presentation of lupus. So we were a little bit suspicious and wanted to get pathology and additional tissue to help us with this. We thought about the possibility of a lymphoproliferative disorder, which Jori mentioned. We have lymphadenopathy everywhere. And some of these can interestingly mimic lupus. So Castleman's disease is a lymphoproliferative disorder. And some of those patients can interestingly have positive ANA and low complements. And they can actually get proteinuria as well. And so we consider the possibility, is this a lymphoproliferative disorder, or is this a malignancy with her lymphadenopathy everywhere? And malignancy is another cause of a mixed autoimmune hemolytic anemia. So we did ask to get an excisional lymph node biopsy, and she had a PET scan, and then they biopsied the FDG avid axillary lymph node. And this showed loss of normal follicular architecture replaced by an infiltrate of small and large lymphocytes with scattered larger B-cell immunoblasts. Small lymphocytes were almost all follicular helper T cells expressing CD4, CD10, and BCL6. She had immunohistochemistry staining for CD34, which highlighted the endothelium. So there was increased blood vessels. And so this combination of follicular helper T cells, B-cell immunoblasts, and this vascular proliferation in conjunction with her presentation led to the diagnosis of angioimmunoblastic T-cell lymphoma, or AITL. So, Jori, I'll let you comment on your thoughts about
Ooh.
this, and then I'll add what we were thinking.
Yeah. So, wow, that's not a diagnosis that you see every day, right? But I think rather than focusing on kind of the details of that diagnosis, I think the broader stuff of what got us there, right? I mean, we knew that there was pathology that was some sort of systemic disorder. Certainly concerned for an autoimmune process, but within that spectrum, always have to think about those lymphoproliferative disorders and hemolignancies because they can very closely mimic each other and cause autoimmune phenomenon. So, that's kind of how I think, led to this case. And then ultimately, right, tissue is the issue. I think that is very well said. That getting a biopsy, and particularly here, excisional biopsy, right? An FNA is not the answer if you are concerned about any sort of hemolignancy, any sort of these kind of abnormal lymph disorders that cause lymph node involvement, right? Because you need that lymph node architecture. That's essential to making this diagnosis. So proceeding with that axillary lymph node biopsy was really what was necessary, and led this team to the correct diagnosis. Interested to hear how, if and how she responded to treatment. I think there's a lot of variation in IEITL about how these people respond and how they present, and then ultimately their prognosis. So interested to learn a little bit more about her course.
Sure. So, I think when thinking about this case, I think it was very interesting because there were a lot of features that sort of mimicked lupus, and there were a few clues from the rheumatology perspective that made us a little bit suspicious. So one, I briefly mentioned as I did the final aliquot and reveal that her age was a little bit older for new diagnosis of lupus. It's classically presents in, it can present in childhood or reproductive age women. And, there's some thought that estrogen may play a role in the pathogenesis. And so it's less common in postmenopausal women, although I've seen new lupus with new lupus nephritis, even in the late 50s, 77 would be quite rare for that. And then the absence of CNS inflammation was a little bit suspicious because if she was this sick from, lupus cerebritis, we'd kind of expect to see inflammation in her CSF. And so the fact that the LP looked so clean was a little bit concerning, and we sort of raised our eyebrows at that. And typically if it's a younger patient with classic signs and symptoms, with a presentation of lupus, we don't always necessarily get a lymph node biopsy if they have some lymphadenopathy. But I think in a lot of cases, it is very, very helpful to try to get pathology. And certainly if you're concerned, with diffuse lymphadenopathy, malignancies in your differential, agree that doing that excisional lymph node biopsy. And like I said, we'll always try to get biopsy with any proteinuria if there is renal involvement. So with AITL, this form of a malignancy is associated with substantial immune activation in the lymph nodes and the peripheral blood of patients. So there's increased cytokines, circulating autoantibodies, and immunologic phenomena. So even though that can be seen with really any malignancy, it's quite common in AITL, including ANA, positive DAT, circulating immune complexes causing low complement levels have all been described. And interestingly, autoimmune hemolytic anemia has been described with AITL. So that is sort of what led to this diagnosis. Unfortunately, in terms of prognosis, she did have basically progressive respiratory failure and a lot of systemic involvement. She was started on chemotherapy in the hospital, but I think because of her functional status, they decided to do cyclosporin, I believe. And unfortunately, she did end up passing away while she was in the ICU, from this. But I thought it was an interesting case to kind of think about and work through our differential for anemia, for positive ANA, and then thinking about, more broadly, what are the steps to sort of work up the potential diagnoses in this differential. So that is all I have, and I'll kick it back to Anne-Marie and I think the teaching points.
Awesome. Thank you so much for this fabulous discussion. And I loved hearing like rheumatology and hematology like come together just for, and immense of pearls and knowledge. So I'll pass it over to Sakriti to finish up, but thank you so much, Mithu, Jori, and then also Valet and Sakriti for doing teaching points.
Thanks, Anne-Marie. This was a fabulous case and so well discussed with so many pearls. I was having a hard time keeping up. But essentially, maybe I can just recap the kind of course that we took. We began by investigating the symptoms, which in the first aliquot we got in the form of the altered mental status, the anemia, and we kind of in our systematic approach to this, we identified the pivot, which was altered mental status, because it indicated the presence of a systemic pathology. And then we filtered the anemia and the positive ANA. So with AMS and the positive ANA, we thought about lupus cerebritis. And with the AMS and anemia, we thought about, an autoimmune condition like CNS vasculitis with the anemia in the form of anemia of chronic disease. And then Dr. May sort of gave us a first pass approach to labs, even thinking about the labs, as we get the history and physical. So an important branching point in thinking about anemia is your reticulocyte count and index, because it can lead you into two directions. Either is this a suppressive process or is this a consumptive process? And then with the positive ANA, two things to sort of consider is the titer. How elevated is it? Because, positive ANA is frequently found even in the general population without pathology. And the second is the pattern. Although it's important to remember that a positive ANA, even with a specific pattern, is still relatively non-specific and non-diagnostic. And the 5 sort of things to remember with the positive ANA is lupus, rheumatoid arthritis, scleroderma, Sjogren's, and myositis. In the next aliquot, we began collecting clues, and we got these in the form of the physical exam. So we put together the lymphadenopathy, the tachycardia, and the alopecia. And we heard Dr. May sort of make sense of this lymphadenopathy. So on a first pass, with just the axillary lymph node being enlarged and her age, we thought about breast cancer, but the presence of the inguinal lymphadenopathy again swayed us towards a more systemic process, and we were thinking about the differential for generalized lymphadenopathy. And at this point, even though our pre-test probability for autoimmune was so high, given the positive ANA, it was important to not anchor ourselves in that, and then think about infections and malignancies, especially given her age. And I think something that we learned today is how a lymphoproliferative process can so easily mimic an autoimmune process, in that it both presents like it and can also lead to an autoimmune pathology. And then the rash here, so with the rash and the pretest probability being high for an autoimmune process, we thought about, is there a vasculitis? We also learned from Dr. Mithu about the interface dermatitis that you see on biopsy. That's classic for lupus. And then as we dwelled further into this case, we began to frame our hypothesis. So we put together essentially the key features in this case, which were the anemia, the thrombocytopenia, the positive ANA, the lymphadenopathy, the proteinuria, and the alopecia. And so at this point, at the top of our differential continued to be the diagnosis of lupus, but we also thought about things like APS, TTP. This was less likely given that on the peripheral smear, we didn't see schistocytes. We thought about IgG4 disease, but Dr. Mithu mentioned with the severity of the anemia, this was probably less likely. And another one to consider was hypertrophic pachymeningitis. And really the pivot of this case came in the form of the DAT, the IgG and C3 positive DAT. So along with the elevated cold agglutinin titers. And so we learned that the IG, and so we kind of learned the difference between warm autoimmune and cold autoimmune that we can make out using these. So warm is usually IgG positive or IgG and C3 positive. And with cold, we get IgG negative and C3 positive because it's an IgM mediated process. And then we thought about, cold agglutinin disease. These are frequently associated with lymphoproliferative conditions, as well as infections like EBV, mycoplasma, could also be idiopathic. And then just with the local complement, Dr. Mithu reminded us to think about APS and not anchor ourselves in SLE. And then Dr. May also gave us a great clinical reasoning, Paul, that with cold agglutinin disease, usually this condition doesn't respond to steroids unless there's a process, an underlying process that is causing the cold agglutinin disease that is responsive to steroids. And something for all of us to remember on our boards, transfusion in autoimmune hemolytic anemia is transfused with the least incompatible blood. We also sort of developed a small illness script for lupus cerebritis. So it's really a condition where the patient has neuropsychiatric symptoms. And on labs, you see an elevated oligoclonal band on the CSF. And they may or may not have MRI changes because the small vessels are affected. And we learned that if you suspect CNS vasculitis, as Dr. Mithu mentioned, conventional MRA is the way to go. And I think kind of just going back to the roots of our clinical reasoning here, taking into account the problem representation, who this patient was, given the patient's age, kind of directed us towards the diagnosis and kind of the tissue being the issue in the tissue sort of confirmed our suspicion. So I learned so much. Thank you, guys.
Thanks for having us.
Thanks, everyone. Bye.